Morning again. Now I'm gonna to speak about interventional radiology in GIT bleeding. So at the beginning, we should have a very clear definitions about the upper GI bleeding, which is arising from the esophagus, stomach, and proximal duodenum till the ligament of Treitz. Mid-intestinal bleed, it's arising from the distal duodenum to the ileocecal valve, while the lower intestinal bleed is the patient who would bleed from the colon or the rectum. So what's the cause of the upper GI bleeding? The most important causes are the peptic ulcer disease, varices, gastroesophageal varices, erosive esophagitis, gastritis, duodenitis, while there are different other causes for upper GI bleeding. We should take care about the aortoenteric fistula, which is the hidden cause. We should put it in our mind. A patient who had a lower GIT bleeding, the differential diagnosis will be the diverticulosis, which is the most important cause. Other cause, angiodysplasia, hemorrhoids, colitis. So these are other rarer causes of bleeding for a lower GIT bleeding. So in order to treat this patient, so we should diagnose him very well. So we have imaging, we have CT scan, and this is a very, very important paper published in 2007 about the patient with acute gastrointestinal bleeding. What is the role of CT angiography as a type of diagnosis for this type of patient? So what is angiography? Angiography is imaging of the blood vessels. So we have CT angiography, which role is diagnostic only, diagnose patients with GIT bleeding, while the catheter-based angiography or DSA, it has advantage of diagnostic and treatment intention. We treated patient by embolization. So in a patient who are diagnosed by CT angiography, it's advantage, it's diagnosed patient with active bleeding, whether upper GI or lower GI. We also see the secondary sign which can help us for diagnosis, which are the high attenuation clot inside the vessels. We can see also pseudoaneurysm. We can see the vessel cutoff and vessel irregularity. All these are secondary signs for patients with bleed and or localize the site of bleeding. Also, there was some signs between the DSA and CTI, which are similar signs. The drawback or these are we use contrast. In patients with renal impairment or patients who are shocked from the bleeding, so this is a drawback for this type of diagnosis. So what about a comparison between them? So in patients who are bled from the GI tract, we should know that the bleeding is intermittent. So CT angiography may be done at a time in which the patient is not bleed. So we should know also that the contrast in the bleeding vessels, CT angiography, it takes time only 60 seconds. So the patient should bleed at this time of bleeding, while in DSA, we can diagnose the bleeding between 1 to 10 seconds. Contrast sensitivity in patient who has a CT angiography more than patient with DSA, and the bleeding rate for a DSA, we can detect rates up to 0.5 millimeter per minute, while CT angiography is most sensitive, 0.1 to 0.3 millimeter per minute. The other type of imaging are one of the very, very important, which is the radionuclide scan. We have two different methods of radiopharmaceutical. Is technetium labeled sulfur chloride and technetium labeled RBCs, which is the one who is very famous and available actually is the technetium backed RBCs. So this slide, I like it very much. So it compare all the different three modalities with the bleeding rate. So angiography can detect bleeding rate between 0.5 to 1 millimeter per minute, while CT angio is more sensitive, 0.1 to 0.3 millimeter per minute, and technetium backed RBCs 0.1 milli per minute, and it's rate dependent time, so we take delayed picture until it's positive. So this is very sensitive. However, it's not available in all centers or hospitals. So when we diagnose a patient, we should go for further next for our role, which is embolization. We should know that the upper GI tract, it's very rich collateral and has very rich collateral with extensive collateral supply, while the lower GI tract is the end vessel, so it has poor collateral. And this goes for how we treat this type of patient by embolization. So in patient with upper GI with a very good collateral, we can go for distal and proximal embolization. We can use different type of embolizations. While in patient with low GI bleeding, we have to go very selective and perform very selective occlusion with only some type of embolizing material, which we'll discuss next. And we have to go very distal, getting to the bleeding point to preserve the variability of the bowel, as we said before, that they are not very rich in collateral supply. We have different type of embolizing material, including the permanent and the temporary. We have the permanent, including the coils, the particles, and the glue, and the temporary ones are the gel foam slurry. So the coils, we have different type of sizes, and we can put it on a standard catheter or even the micro catheter, and it works by slowing the flow of the blood vessel, so it initiates a clotting around the fibers and around the damaged endothelium. So this, it may not work in a patient with coagulopathy. The other type of treatment is the liquids, which have permanent and temporary. The permanent one are PVA and the temporary one are the gel foam. So we have to go distally to embolize it, or even proximally. It works in coagulopathic patients, and we use it in the upper GIT tract patient. We don't use it in the colonic bleeding. And the other one, which is a liquid, is a glue plus Lipido. It's not preferred to use it in GIT bleeding, only in few lesions. It has a much to being a quick embolizing material, but it's less controlled, and we don't like to use this in GIT bleeding. So we have a case here, 51 years old male, presented by hemoglobin drop up to 8.2. There was a history of repeated melena and repeated blood transfusion. Patient has 4 cardiac stents, and patient on Plavix, creatinine was very high, and there was family history of cancer colon. Patient admitted to the ICU for repeated blood transfusion. So we decided in this patient to do a CT angiography in order to help us. So we performed CT angiography. As we see here, we saw well circumscribed small enhancing mass in the small bowel, probably the ileum here. So, and there was a target sign of a small blood vessel here. So we were very happy to see this because this is probably the site of GI bleeding. So we decided to take the patient to the cath lab and do angiography. And actually we saw same area here, abnormal blush from the blood vessels of the ileal branches here. This mass here, this is small mass, as we see here, rounded. So we entered very, very selectively, and we embolize it by particles. Then we took the surgical consultation because the patient has a history of family colonic cancer, and the surgeon decided to resect it, and it was a GIST tumor. Another case of 75 years old male. This patient complained of passage of black stool for about 2 days. Patient had multiple comorbidities, and blood pressure was 120/70. Heart rate is 90, and patient was ICU admitted for shock and received 7 units of blood. Patient on vasopressor. Okay, so they called us. And upper GI bleeding, duodenal ulcer. They did an endoscopy, which cannot be stopped by usual endoscopic maneuver. So the endoscopist called us, and we have possible for immediate possible intervention, and this decision was made for immediate angiogram and stop the bleeder and embolize it. Procedure done within half an hour from our call, and we did a GDA angiogram because the bleeding was in upper GI bleeding, and you see here a small branching bleeder from one of the proximal branches of the gastroduodenal artery, which is the supraduodenal artery. We enter very selectively by the microcaster. We confirm the bleeding here, and we embolized it with one coil here, very selective. We embolize the supraduodenal artery, and this is picture after the embolization reveals cessation of any bleeding. And 1 day after the procedure, the patient was stable and stopped the vasopressor. Blood pressure returned to normal. 2 days after the procedure, patient transformed from ICU to general ward, and melena stopped. Thank you so much.